A warm good morning to one and all. The topic for the discussion is habits. And going to the content, we are going to see about definition, classification, thumb sucking, tongue thrust, mouth breathing, bruxism, nail biting, and lip biting. A habit is a fixed practice produced by constant repetition of an act, given by Thompson in 1927. At each repetition, the act becomes less conscious, and if repeated often enough may be relegated to subconscious mind entirely. Classification of habits. According to William James, it is classified into useful and harmful habit. It has been classified into compulsive and non-compulsive habit by Finn in 1987. In 1971, Klein has classified the habits into meaningful habit and empty habits. According to Morris and Bahana, it has been classified into pressure habits, non-pressure habits, and biting habits. It has also been classified into normal and abnormal habits, physiologic and pathologic habits, and also as retained and cultivated habits. First, we are gonna briefly see about thumb sucking habit. Thumb sucking. It is defined as placement of the thumb or one or more fingers in varying depths into the mouth. Theories behind thumb sucking habit. First comes classic Freudian theory, which is also known as psychoanalytic theory. Orality in the infant is related to pregenital organization, and the sexual activity is not yet separated from taking of nourishment. Thus, the object of one activity, thumb sucking, is also that of another, which is nursing. The next theory is oral drive theory given by Sears and Weiss in 1950. Their work suggests that strength of oral drive is in a part of function of how long a child continues to feed by sucking, but rather oral device which has been strengthened by the prolongation of nursing. In 1960, Benjamin gave a theory which says that thumb sucking arises very simply from the rooting and placing reflexes common to all mammalian infants. These primitive reflexes are maximal during the first 3 months of life. Harriet et al. In 1957 tells that digital sucking is a learned pattern of behavior with no underlying causes and no more emotional and psychological problem. Finger sucking habit from birth to 4 years of age. Feeling sense of security, feeling warmth of association, of being wanted. That is, all these get into infant through suckling. Thumb sucking habit considered normal for the first 1 year and half of life will disappear spontaneously by the end of second year. For the first 3 years of life, damage to the occlusion is confined to the anterior segment. It is temporary provided the child starts with a normal occlusion. Active finger sucking habit after age of 4. The permanent deformation of occlusion can increases markedly in children, continuing the habit beyond 3.5 years of life. The clinical aspect of the problem of thumb sucking may be divided into 3 phases. Phase 1, normal and subclinically significant sucking. This may be from birth to 3 years. Sucking is naturally resolved at end of phase 1. Otherwise, the use of rubber pacifier towards the end of phase 1 is much less harmful from dental point of view than repeated vigorous thumb sucking. Phase 2, clinically significant sucking. This phase extends from 3 to 6 or 7 years of age. It is a possible indication of clinically significant anxiety. It is best time to solve dental problems related to digital sucking. Then comes phase 3, which is also known as intractable sucking. Such cases require dental and psychological therapy. Consultation with the physician and psychologist may be made in order to develop an integrated approach. Classification of thumb sucking by Supton Lee in 1973. Group 1, it is the largest group, comprises of 50% thumb, was observed to enter into the mouth considerably beyond the first joint, which can be depicted in the picture. Group 2, it is usually entered into the mouth up to and around the first joint or just anterior to it. In Group 3, the thumb passed fully into the hard palate as in Group 1. In Group 4, the thumb did not progress appreciably into the mouth. Sequelae of thumb sucking: increased overjet, lingual tipping of mandibular incisors, proclination and spacing of the maxillary anterior teeth. Sequelae of thumb sucking: anterior open bite, compensatory tongue thrust, narrow nasal floor and high palatal vault. Bilateral posterior crossbite may develop as seen in the picture. Diagnosis of thumb sucking consists of 4 procedures: history of thumb sucking, emotional status, extraoral examination, and intraoral examination. Measures to discourage the development of sucking habits, proper nursing of the child, proper care of child by parents, use of physiologically designed nursing nipple. When pacifiers are to be used, select properly designed pacifier. Various measures used for correcting the thumb sucking habit. Apply a non-palatal substance to the thumb or finger. Apply a bandage to the thumb, finger or the entire palm. Explain the child with the help of audio-visual aids to show that they might develop crooked tooth if the habits are continued. Beta hypothesis. This method of correcting the habit is known as Dunlop's beta hypothesis. It is the best way to break the habit. Here are some mechanical aids. Under removable appliance, we have remainder appliance, simple acrylic plate, then rakes and palatal crib are also used. And down the picture shows the oral screen, which can also be used in case of thumb sucking. Under fixed appliance, bluegrass appliance, non-primitive fixed appliance using Teflon roller used to manage digital sucking in children between 7 to 13 years of age. Then comes quad helix. It is used to expand the constrictor maxillary arch. Helix of appliance serve to remind the child not to place the finger in the mouth. The next habit we are going to see is tongue thrusting. The abnormal positioning of tongue to varying degree has been termed as tongue thrust. Classification of tongue thrust. According to Myers, it has been classified into normal infantile swallow, normal mature swallow, simple tongue thrust swallow, complex tongue thrust swallow, and retained infantile swallow. Etiologic factors developed by Flett. Genetic factors. Palmer, Subtenley et al. Suggest that a type of maxillary structure which favors development of tongue thrust may be hereditary. Learned behavior. Learned behavior. Improper bottle feeding, prolonged period of tenderness or soreness of gum tissue and teeth, keeping the teeth apart during swallowing. Prolonged thumb sucking with the habitual movements generalized to tongue activity. Tongue held in open spaces during mixed dentition. Prolonged tonsillar and upper respiratory tract infections. Tongue thrust as an evidence of late maturation from infantile suckle swallow. Diagnosis based on morphologic examination, size of tongue, functional examination, cine-fluorographic analysis, barium solution, clinical diagnosis of tongue thrusting. Simple tongue thrust. It is defined as the tongue thrust with teeth together swallow. Malocclusion which is associated with it is usually well circumscribed type of open bite in anterior region. Cuspal interference are not present and there is perfect fit of posterior teeth in occlusion. Intercuspation is firm but the antero-posterior relationship is not necessarily correct. It is associated with abnormal function of lips, mentalis and other circumoral muscles. Anterior lip seal is made partly with teeth and partly with the lips. Teeth are held together prior to throughout swallowing. Treatment, steps in correction. Learning of a new reflex at the conscious level, that is, teach the exact position of tongue by pointing with patient's own index finger. Ask the patient to swallow by holding the tongue in that position. Transferal to the subconscious level. By this position, it is to reinforce the reflex at subconscious level done by placing flat sugarless fruit drops at the position occupied by tip of tongue. Appliances. If proclination is severe, treat the procumbrancy of teeth first and then correct the habit. Use of habit breakers, both fixed and removable cribs or rakes, are valuable aids in breaking the habit. Complex tongue thrust. This is defined as the tongue thrust with teeth apart swallow. Poor occlusal fit resulting in a slide into occlusion. There is a generalized anterior open bite, absence of temporal muscle contraction during swallowing. There is dropping of mandible and strong contraction of circumoral muscles. Treatment. Similar to the management of simple tongue thrust. However, the occlusal correction should be carried out only after the correction of the habit. In spite of clinicians' best efforts, there will be partial relapse in some cases. Retained infantile swallow. This is the persistence of the infantile swallowing reflex even after the arrival of permanent teeth. Persistence of infantile swallow is indicated by protrusion of the tip of tongue, contraction of perioral muscles, no contact at molar region during swallowing. Next habit we are going to see is mouth breathing. Mouth breathing and its association with malocclusion is a complex tissue. Very rarely there is complete nasal obstruction. Therefore, mouth breathing can be termed as oronasal breathing. Some individuals may appear to be mouth breathers because of their mandible posture or incompetent lips. It is normal for a 3 to 6 year old to be slightly lip incompetent. Other children have been labeled mouth breathers because of a suspected nasal airway obstruction. Mouth breathing can particularly affect the growing face. The alterations will occur in the muscles associated with the face, jaws, tongue and neck. The abnormal pull of these muscle group on bones of the face and jaws slowly deforms these bones, eventually causing the jaws and teeth to be mismatched. Other causes of reduced nasal respiration include asthmas, nasal polyps, etc. Classification according to Finn. It is obstructive, habitual, and anatomical. Obstructive mouth breathers. Children who have increased resistance to or complete obstruction of the normal flow of air through the nasal passages. Frequently observed in ectomorphic children who possess long, narrow faces and nasopharyngeal spaces. Habitual mouth breathers. Child who continually breathes through his mouth by force of habit, although the abnormal obstruction has since been removed. Anatomical mouth breather. One who short upper lip does not permit complete closure without undue effort. Mouth breathers have a typical appearance described as adenoid faces. Clinical signs as follows: long narrow face, narrow nose and nasal airway, flaccid lips with short upper lip, excessive eruption of posteriors, constricted maxillary arch, excessive overjet, anterior open bite, mandibular down forward growth is poor. Mouth breathing sequelae, soft tissues. Lips stay open, dry, action of lip on upper incisor is lost. Cheeks pulled downward and become narrow. Gingiva, persistent marginal gingivitis limited to anterior region. Mucous membrane, dry and prone to inflammation. Speech, nasal tone because of paranasal sinuses are poorly formed which give resonance to voice. Hot tissues, inhibition of growth of premaxilla, anterior open bite, increased overjet, class 2 division on malocclusion. Diagnosis of mouth breathing. History. A good history should be recorded from the patient as well as parents. Clinical examination. Look for various clinical features. Study the patient breathing unobserved. Ask the patient to take deep breath. See for external nares. Butterfly cotton wool test can be done. Ask patient to hold full mouth of water and hold their breath. Cephalometric examination helps in establishing the amount of nasopharyngeal space. Size of adenoid also help in diagnosing the long face association with mouth breathing. The only reliable method of determining the mode of respiratory function is to use the plethysmograph and airflow transducers to determine total nasal and oral airflow. Treatment of mouth breathing, elimination of underlying pathology, interceptive lip exercises, appliances like oral screen, etc. Next, we are going to say about bruxism. It is commonly defined as gnashing and grinding of teeth for the non-functional purposes. Signs and symptoms. Occlusal or incisal attrition patterns that do not conform to or coincide with normal masticatory or swallowing wear patterns. Wear facets are seen at the incisal tip of maxillary cuspids. They are often rounded over the labial surface of cuspid. They are also seen on incisors, bicuspids as well as on the other teeth. In patients who have denture, their wear may be more severe on the posterior teeth than the anterior teeth. Unexpected fractures of teeth are restorations. Unexpected mobility of teeth are restorations. Increased tonus and hypertrophy of masticatory muscles. Soreness of masticatory muscles. Tenderness on palpation. Tender spots more common along the anterior and lower border of the masseter and medial pterygoid and also in temporal regions. Complain of tired feeling in the jaws when they wake up in the morning, or they experience a locking of jaw, and the masseter and temporal muscles have to be massaged before the jaws can be opened. Patients with hypertonicity of jaw muscles and bruxism may bite their cheek, lips and tongue accidentally as a result of sudden contraction of these muscles. TMJ discomfort and pain. Since bruxism has dual cause that includes psychic and occlusal factors. Methods of treatment: psychotherapy, relaxing exercise and physiotherapy, elimination of oral pain and discomfort. Relaxing exercise and physiotherapy. Relaxing exercise, both of general and local nature, may save to decrease the muscle tension and bruxism. Exercise, massage, heat and other form of physiotherapy will provide some relief for bruxism. Occlusal therapy. Occlusal adjustment to eliminate the prematurities, occlusal equilibration. Elimination of occlusal interferences by restorative therapy using inlays, onlays and replacement of missing teeth. If neither of these two steps is successful, a mouthguard-like appliance can be constructed of soft plastic to protect the teeth and attempt to eliminate the grinding habit. Next comes lip biting and lip sucking habit. It sometimes appears after forced discontinuation of thumb or finger sucking. Often involves lower lip. Patient may exhibit proclined upper anteriors and retroclined lower anteriors. Hypertrophic and redundant lower lip. Cracking of lips is also seen. An appliance known as lip bumper is used to correct this. Thank you so much.